Good evening, all. So let's start with the case. So while you are in an OP, there comes a 50-year-old female who is suffering from CA pancreas, who presents to your OP with sudden worsening of abdominal pain. There is a constipation of 7 days, and she's also complaining of severe vomiting and even not even able to take anything orally. Even she's taking sips of fluid, she starts vomiting. Her vitals are normal, but her abdomen looks distended and is tender. On examination, you couldn't find any bowel sounds. And you took a X-ray erect and it's shown there. So what do you think is the diagnosis for this? We have a 50-year-old female suffering from CA pancreas with sudden worsening of abdominal pain. There is constipation, severe vomiting, distended abdomen, no bowel sounds, and X-ray.
Participants, please put your replies in chat box.
Or you could speak up.
Unmute yourself and speak, or either you could put your answers in the chat box, please.
Anyone else? Anybody with any other opinion? Ascites. There could be ascites, yes, but that's not something that is causing this abdominal pain and constipation. Severe vomiting. Yes, abdomen ascites indeed can lead to this condition. Okay. Yes, it's a bowel obstruction. Yes, its answer is correct. What has been answered. So whenever a patient with an advanced cancer within the abdomen presents with a severe sudden worsening of pain, distension, and constipation associated along with vomiting, the first thing you have to come into your mind is an intestinal obstruction, which is a palliative care emergency where we need to intervene immediately because that's a very life-threatening situation. So if you see this, X-ray erect is a gold standard investigation for this. It's very one of the economical and very helpful investigation of choice. So if you see this X-ray, I will put up a closer one. So what? If you could see this, there are multiple pockets here, which are semicircular. see this, these are fluid levels. And these are air packets and these are fluids. There are multiple air fluid level packets seen in the X-ray. You could see this here, here, and here. These are diagnostic of an intestinal obstruction. Okay. So what's an intestinal bowel obstruction? So intestinal obstruction, it usually happens at 4 levels. Initially, the gastroesophageal junction, where this the esophagus and the the stomach joints, we have the gastroesophageal junction. That is a very common site for intestinal obstruction. Then it could happen at the gastric outlet and proximal small bowel, like the gastric outlet and the proximal small bowel, like the duodenum. Then there is a distal small bowels, and or anywhere in the large bowel. So intestinal obstruction could happen any of these places. So it could either be a mechanical or a functional one. So what happens in mechanical is that something, a live organ, a structure will be obstructing the bowel, like a tumor in the abdomen, which could grow in size and could be compressing the lumen, thereby causing obstruction. Because in case of a functional obstruction, what happens is the peristalsis of the abdomen stops. There is a failure of peristalsis, thereby functionally obstruction is happening. When we take a food, the peristaltic action of the intestinal lining moves the food forwards. Here, when it's not functioning, the food doesn't move; it gets stuck there and causes an obstruction. So that's the two types of one type of obstruction. Peristaltic failure is usually seen in electrolyte abnormalities. That's what, then there could be a partial or incomplete obstruction and a complete obstruction. In case of a partial or incomplete obstruction, the patient, the most common clinical history, the patient is going to say he would be past flatus, he would be constipated, but still he could be able to pass the flatus. Patient would present to you in case of a partial or incomplete obstruction, where the obstruction has set in, but it hasn't completely covered the intestinal lumen. Then there is a complete obstruction where whatever the causing is completely obstructing the intestine, then there won't be a patient won't be able to passing flatus in last 72 hours. There could be hyperactive, or there would be no bowel sounds itself, and colicky pain would be there. Another classification is acute or chronic. So whenever a patient comes with a long-term constipation and lower abdominal cramps, always think of a fecal impaction. The fecal material could be impacted, causing the obstruction. So a little pathophysiology of the intestinal obstruction. Okay, so this is a representation of our intestine. While we eat the food comes here, and the obstruction happens here. Okay, so there is no passage of stool or gas, and the proximal proximal to the obstruction. What happens is whatever the food or the gastric contents comes through the mouth, or it gets accumulated there along with the swallowed air. So there is increased contraction of proximal part because the food is coming on, it's not stopping, the gastric secretions are coming, the air swallowed is coming, and the intestinal, of course, it will try to push it part to the, it will try to overcome the obstruction. So there is increased contraction in the proximal part, the part before the obstruction, which is the most common. This is causing the colicky abdominal pain and also the vomiting, because they are trying to compress it and the food may come back through the mouth, that causing the vomiting. After some time, there is dilation. There is the proximal parts get dilated because it's not moving on, it's accumulating. The stomach gets dilated, and the food which has been also there, the bacteria in the stomach starts acting. There will be gases forming. The gas will also be adding to the dilation. There is increased intra-abdominal pressure, and the abdomen starts distending. Once it starts distending, the arteries and veins around the part will also start occluding, and there develops edema. The bowel wall will become edematous. Likewise, since it has been there for long, there is no movement. The bacteria, which is already bacteria, organisms which are already in the stomach, they starts acting on the intestinal lumen, and the lumen, the wall of the intestine starts necroting and leads to perforation. Once perforated, the intestinal contents escapes into the peritoneum, causing inflammation, causing a severe condition called as peritonitis. Then usually presents with the fever, abdominal guarding, and tenderness. Patient will have severe abdominal pain here, and the patient may go into shock and lead to death. This is a pathophysiology of intestinal obstruction. What happens in an obstruction? Coming to the most common causes of obstruction, of course, is cancers, especially the cancers which are in the intestinal content, intestinal region. CO ovary is one of the most common causes of intestinal obstruction. Then there is C pancreas, C rectum. They are all most commonly causing intestinal obstruction. So whenever a patient with an intestinal tumor comes to you, always think about intestinal obstruction. Then there are past treatments which has taken place, like a surgery which has undergone, the patient could have undergone, or a radiation to the abdomen. Those can also lead to obstruction. Like or surgically, there could be adhesions. The intestinal wall could adhere together, then causing obstruction. The radiation to abdomen may cause ischemic fibrosis. Then there are drugs like opioids and antimuscarinics, which are most commonly taken by our patients, can also cause it. Then debility, like fecal impaction and electrolyte imbalances. So, which all electrolytes do you think causes intestinal obstruction? Let me turn the question. Which all investigations will you send? Electrolyte investigations will you send while a patient presents with an intestinal obstruction for you?
Participants, please unmute and speak yourself.
Okay, yes, electrolytes and CBC, yes. Which electrolyte in specific is my question? Yes, sodium. Okay. Okay, potassium. Good. I'm waiting one more electrolyte. Waiting for one more electrolyte that should come out. Magnesium. Okay. There it is, the calcium. Yeah. So start from the beginning, but so Thomas said that sodium. Hyponatremia doesn't cause obstruction, but it will be present along with the cell obstruction. But potassium, magnesium, and calcium, yes, they are there. Magnesium is not very commonly seen because loss of hypomagnesemia is seen like distal colostomy cases. Potassium and calcium are most commonly causing the cell. One thing is we could have a base diagnosis of location, the site of obstruction, usually from the clinical features. Like a patient who is liquid second, so the patient will be coming that he's difficult to swallow the food. He's facing some difficulty, feeling like some obstacle food like rice or chapati or something. Later we develop difficulty in drinking the liquids also. This is usually seen in an esophageal obstruction. Likewise, when for severe vomiting with even with a small quantity of food, retrosternal or epigastric discomfort and gastric distension are commonly seen in gastric and small intestine obstruction. In case of distal or large intestinal obstructions, the vomiting is less frequent, but there is chances of foul smelling vomitus. Even there could be presence of fecal and vomiting, that the vomitus would be containing fecal matters. It will be very foul smelling, just look like a fecal matter because the obstruction happens as a large intestine. Then there could be abdominal pain, which often could be a colicky pain. Then there is constipation and some case diarrhea, like a secondary diarrhea. Then the bowel sounds could be absent in functional and even hyperactive in mechanical. So always check for a bowel sound in your patient. So the investigations, the basic investigations you could send is for a calcium and potassium, where the hypercalcemia and hyperkalemia can lead to intestinal obstruction, where they could cause a functional obstruction. Likewise, the economical one is an abdominal X-ray, which in a erect position would be the better one. You could see, visualize as I already show you, multiple air fluid levels. Then there will be distended loops can be seen on the abdominal X-ray. CT is of course the confirmatory one, and usually use CT would be suggested for patients who are planned to undergo a surgery for the intestinal obstruction correction. Since intestinal obstruction is an emergency, surgical corrections is often indicated. So when can we post a patient for surgery? There are some indications, like the patient has a good general condition, the patient is healthy, good general condition, there's a single discrete organic obstruction, a single obstruction, the disease is not disseminated, very localized tumor or something. The patient could be very independent and active patient who had a weight loss less than 9 kilogram. And of course, the patient who is willing to undergo surgery, it's an abdominal surgery, it's very complicated, it would be a complicated one. And the patient is willing for surgery, yes, you can go for a surgery. Because you should also know when the patient should not be sent for surgery. Like a diffuse intra-abdominal tumors, multiple palpable mass, re-obstructions. So often what happens is a patient who presents with intestinal obstruction, once we are able to correct it, there are risks for a re-obstruction. So unless the causative factor is removed. Okay. So there are chances of re-obstruction, and history of a laparotomy, abdominal radiation history, poor nutrition, poor general condition, and a large ascites is a contraindication for surgery intervention. because the outcomes expected are very poor in such conditions. Okay, this is a cycle. Once an obstruction happens, the patient's intestinal gas distension occurs. Once the distension occurs, it will lead to increased secretion and reduced reabsorption will be reduced, which indeed leads to mortality. This is a cycle which goes all three ways to them. The reduced mortality can cause increased secretion and reduced reabsorption. It itself can cause GI distension. So why the secretion, increasing secretion is important? Because once the secretion increases, the abdominal distension increases and the patient's discomfort will be increased. So how do you manage an incomplete malignant bowel obstruction? So incomplete means the lumen has been fully completely obstructed. The patient will be able to pass flatus. There will be colic pain and vomiting will be also there. So here, since it's not complete, we could always go for an oral trial of steroids. What is the indication of steroids is a question. So what if we are planning, so what happens is when a tumor is causing the obstruction, dexamethasone is an anti-inflammatory agent, as you know. So it will decrease the peritumor edema, the edema that is present around the tumor, thereby shrinking it to a level, so that the obstruction gets cleared. And it also is a anti-emetic action. Then we have to give a PPI, a proton pump inhibitor like a pantoprazole or omeprazole and a ranitidine. Which one will you prefer, proton pump inhibitor or ranitidine? For a patient with intestinal obstruction, which one will you prefer? And why? If you prefer a proton pump inhibitor, why? If you prefer Randac or ranitidine, why?
Anybody has anything to tell? If you have anything to answer, please unmute yourself and speak.
Yes, last time, Swami. The answer you said is very correct. Ranitidine is the best choice of antacid in such cases of a malignant bowel obstruction. And the reason is also correct. Yes, it's an anti-secretory. So what we say it like this, there will be increased secretion, which will be causing the abdominal distension and discomfort. So if a ranitidine is used on a PPI, it has an anti-secretory action, which will reduce the secretion and decrease the gastric distension and even more. So then the one used hyoscine butyl bromide or parenteral or haloperidol. We could use for antiemetic with or without an opioid because of pain. If there is no colic, we can start with the prokinetics and monitor the response. And continue the antiemetics. If colic pain returns, we conservative management as of a complete malignant bowel obstruction. Okay, so how do you manage an inoperable bowel obstruction? The basic principle is resolve reversible components of the distress and symptoms. Always have the patient. We have to make the patient comfortable. So what they will be presenting with severe pain, nausea, vomiting, and the distension. Those are the most irritating or distressing symptoms the patient will be presenting with. So we have to control the pain, the nausea and vomiting, and distension. As I have already mentioned in my last session, and even you would have experienced, the nausea and vomiting are very distressing thing, not only for the patient but also the caregivers. So, bowel wall swelling and reversible component of obstruction can be used for with help of corticosteroids. As I already studied the pathophysiological part, there will be swelling in the intestinal lumen, which could be controlled with the corticosteroid. Then treat the pain, nausea, and vomiting, reduce the luminal secretions. So we are supposed to, a patient would be having severe pain. So we could even use step 3 analgesics. The opioids can be given throughout the day, sorry, round the clock. Here, one thing is we could, since the patient would be having severe vomiting, we need not opt for an oral route. We could always try for a IV or subcutaneous route. Personally, I would prefer subcutaneous route. Then to reduce the vomiting, we have to put them on antiemetics. And to reduce the level of secretion, antihistaminics and antisecretory drugs has to be given. And always remember for laxatives, because a fecal impaction could always be there, and laxatives must be there, and electrolytes should be always be monitored. If you suspect an electrolyte imbalance and a functional failure, electrolytes should be monitored and corrected. Yes, pain. For the pain, morphine could be given round the clock and SOS. So, if the patient wish to continue at home, and there is no provision for inject a parenteral route of morphine, how do you give a patient morphine? You have to send the patient home with morphine to ensure that the patient has a round-the-clock pain relief. And even if he has a breakthrough pain, an SS dose should be given. And the patient is having severe bowel obstruction, and she at home, there is no possibility for an injection or like a sub-Q or IV route. Which other route could be used? Okay, you could train the patient, the caregivers or a subcutaneous route, but okay, let's think that there is no possibility of the caregiver is very afraid to be. Yes, the per-rectal route. Thank you very much. The per-rectal could be opted. And if there is a colicky pain usually will be there, and antispasmodic and antisecretory, antiemetic could be used. Drugs are better given continuous subcutaneous infusion, so that we are providing symptom-free distress-free life throughout the day around the clock. So when a patient presents with poor general condition, their poor performance status, there will be a very bad peritoneal disease, history of abdominal radiotherapy, CAC is bedridden, and a prognosis which we expect is less than 12 weeks, or the patient or the family makes an informed decision on minimal invasive conservative treatment. They doesn't want to undergo a surgery, who doesn't a patient who doesn't want to be on a surgical table, we could go for a distress-free life with these steps. Okay. So an nasogastric tube is indicated for decompression. Usually the patient will be coming, as we already discussed, the patient abdomen will be distended with secretions. So an nasogastric tube can be used to decompress. Some of the secretion could be removed through a nasogastric tube, but this should be a temporary method, temporary route that we plan we should have only for the distress of relieving the distress of the patient. Then an antiemetic without a prokinetic action can be given. Then continuous subcutaneous infusion of antimuscarinics with or without opioids. Then the antacids, PPIs or amantadine. Then hyoscine butyl bromide as an additional antisecretory. Maintain hydration, pain relief. The patient, the caregivers would always be asking for whether they could feed the patient, and sometimes even the patient would be having some patient would like to eat something, so we could suggest them to sips of clear fluids and licking of favorite fluids. So some say licking of ice cubes would be helpful for them, a relief for them. What if the patient is moribund, is in terminal stage, nearly dying? Nasogastric tube can be used to keep the stomach decompressed, and our aim for an IV fluid, sorry, a parenteral fluid should be only to hydrate him. Subcutaneous saline would be the best option, but we have to convince the family about that. Should be a shared decision. The family should be consulted, and their decision has to be they had to be told about why it has to be given, why it should other fluids should not be given, and the fluid should not be more than 500 to 1000 ml per 24 hours. Analgesia should be ensured, and in severe occasion, if the patient is in severe distress and no other symptoms, no other steps can be used to help him, we have to think of palliative sedation. The patient has to be there distress-free for the end of his life. The patient is already moribund. So if no other steps are going to help him, we have to think of palliative sedation. A little detailed about the drugs used. The anticholinergic or anti-secretory drugs, they are used to reduce the distension and the colicky and spasmodic intermittent pain which is seen. So the drugs commonly used are injection hyoscine butyl bromide. It could be started at a 10 milligram 6 hourly, or even as a continuous subcutaneous infusion. Up to 120 milligram over 1 day can be given. Transdermal patches are available in certain centers. Here, what we use is continuous subcutaneous infusion. Then hyoscine hydrobromide, injection could be used in 0.2 to 2 milligram. Injection glycopyrrolate is also used. It's an antisecretory agent at 0.1 to 0.4 milligram per day can be used. Octreotide injection as a continuous infusion can also be used. It is kind of a costlier one. Ranitidine infusion of 150 to 200 milligram per day can be given throughout the course, reduce the upper GI secretion and the distension. See, the drug used for anti-inflammatory action, the corticosteroids, usually starting with 8 to 16 milligram per day. It could be given slow IV or subcutaneously. Since dexamethasone is a long-acting drug, we could give it for a once-a-day dose. Once the nausea vomiting subsides, in case of a incomplete bowel obstruction, we could always switch for an oral route. And always watch if there is no improvement in the patient's condition with the dexamethasone for like up to 5 days, or if the side effects start appearing, we can discontinue the dexamethasone. We can gradually be, if it's a shorter course, we can suddenly stop If it are given for a longer time, it can be enough. So even if the obstructive symptoms are leaving, we shouldn't stop it suddenly. We could gradually wean over a period of 2 weeks. Of course, as dexamethasone is a steroid which has an anti-inflammatory and an antiemetic action also. The prokinetic antiemetics, what they help do is they will facilitate the bowel movement, like the bowel sounds and the intestinal luminary peristalsis. So if there is already a colicky pain, it will be precipitated by the presence of this called prokinetic antiemetics. So always stop the prokinetics or do not prescribe if the patient has already a colicky pain or the vomiting or the pain worsens once you start it. In case of functional obstruction, prokinetics could be used. We could use with an oral or injection metoclopramide. 10 milligram 4 to 8 hourly can be given. It can be raised up to 30, maximum 40 over for 24 hours. Domperidone is another prokinetic which could be used, which is also available in mouth dissolving and rectal suppositories. In case of severe vomiting, if an IV route is not possible, we could go for this mouth dissolving or rectal suppositories. Then the antiemetics with prokinetic action. So usually the drug of choice would be haloperidol. We could start with always a lower dose of haloperidol, 0.5 or 0.75 milligram once a daily. I prefer it to be at night because to avoid this effects of the sedation. Slowly we could titrate up to 5 milligram over 24 hours. Once you are giving haloperidol, warn the caregiver about the sedation that's going to happen. Then the 5-HT3 antagonists, the ondansetron, the most commonly used NSAID, it can be given at 8 milligram 3 times a day. But one thing you have to keep in mind is ondansetron, it will lead to constipation. It will add to the constipation. Once the patient is already constipated, ondansetron will add to the constipation. So make sure there is enough laxatives for this. So most importantly, the supportive care that you have to give the patient and the caregivers. We have to demonstrate an education on mouth care using lukewarm water with salt and soda bicarbonate. So this will help the relieving the thirst, oral symptoms, and nausea. So what we do is take a glass of lukewarm water. For one glass, we could use 1 pinch of salt and 1 pinch of sodium bicarbonate. Help them rinse them out. That will keep the oral cavity clean. It will help them for the thirst. Excuse me? Okay. And also help with the nausea. The most important thing is a communication. Always look for the insight of the patient and the caregivers. Communicate with the patient and family members regarding the prognosis and how we are able to care with the patient. Intestinal obstruction is a very devastating symptom, an issue they are going to face. So the family has to be aware, family and the patient should be aware of the condition and how we can help him. Okay. And informed, supported, and shared decision making and documentation should always be ensured. Palliative surgery has to be considered when there is possible. If the patient you are seeing will benefit from a palliative surgery, don't hesitate. Go for a surgical option if you believe it is going to benefit the patient. Always help the patient to choose a preferred place of care, whether they would like to be at the hospital or at home. If at home, we make sure they could be handled at home. This was true. Emotional support to the patient and family has to be given. And end-of-life care should always be provided with symptom-free, emotional, and legal required preparations of the patient and family. Unfinished business as religious and spiritual care has to be taken care of. not only the medications, all these things should also be considered for the patient. We have to look at the total pain of the patient. Thank you.
Everyone, please put on your video. Please put on your video for us. We want to see you. Okay, then, if you have any doubts or any queries or any patient stories related to this topic, you can share now. Nobody has anything to ask? Kindly please speak up. If you have any doubts, please put it on your chat box. No patient stories?
So how many of you have seen a case of industrial obstruction?
Sruti, do you have anything to ask? Mirosha, do you have anything to ask? Okay.
Good afternoon, everyone. Sripriya this side from Tipseco. Just wanted to know those who are presently actively seeing patients, can they just put an yes in the chat box, please? Those who are presently actively seeing patients in their career life. Any sort of patients. Am I audible, senior?
Yes, CPM, ma'am, you are audible.
Thank you. No one is presently dealing with patients nowadays. Just wanted to confirm that. Because I believe when I am saying that our programs are intended to make the palliative care reach the people out there through people like you, through professionals like you who are actively reviewing patients, who are actively in touch with patients. That is the sole aim of this program. I think Dr. Arjun will agree with me. Correct, doctor?
Yes, of course.
So unless and until we are not sharing our experiences we are having with the real patients, maybe it could be old as well, it could be sometime before as well, but till the time we are not speaking up, till the time we are not saying something about this, no great change is going to happen in the field of palliative care, which of course we are the volunteers for. We as an organization have been working on this palliative care programs just to make sure that our chairman's, our team's vision is getting reached everywhere. So till the time nurses like you, those who are supposed to be the angels in front of the patients, don't open up, don't speak up, I'm very sorry to say, but the vision will not get fulfilled. Correct, doctor? Pardon me if I'm saying such rude words.
Okay. So yes, sleep said only if we know what you understand. If you interact, we could help you more.
Yes.
Otherwise, we are little bit of helpless in this.
Theoretically, we can go on speaking for days and days. Theoretical parts, theories, various case studies, we can keep saying because we as a team are coming across patients daily. Number of patients in person through telehealth daily. But unless and until we get a feeling of what you're facing in the ground, what you're facing in your setting, we might be not in a position to help you out people. So that is why we have been like, this is the 10th or is this the 10th session, senior, if I am not correct? 12th session. So if unless and until the participants don't speak up, yes, we will be of course delivering our duties, we will be delivering what we are supposed to do, but then it would be a one way. Nobody is going to benefit, no participant will get any extra knowledge from this. So that is why we have been repeatedly requesting you to come up with your experience sharing. Maybe not a case presentation, but anything you have come across your career life, at least you would have practiced nursing in your past days. So any instance you have come across which you now feel would have made a difference, you could have made a difference in the life of some person. That is what we are asking for. Correct?
So I think all of you can see our Dr. Arjun's screen.
So this is our telehealth line. It's a national level telehealth line which Parliament is offering. So anyone who, any patient or a family anywhere in India who needs a palliative care support or a consultation, you can call up this number. And this line is also open for any healthcare professionals who are also needing advice on pain management or palliative care to any patient that you are seeing. So feel free to call us and we will be there to help for you. Even after finishing this course, if you have any doubts or regarding a management of patient, you can feel free to call this. Thank you.
Okay, if you don't have any doubts or any cases or anything else to talk, let's wind up this class. So kindly, please share your feedbacks. The link will be shared in your WhatsApp group. And I think Dr. Arjun had made a wonderful class for us. The class was very informative. Even though it was not interactive, it was an informative class for us. And thank you, Dr. Arjun, and thank you all of you for being with us. And I expect all of you on the next class. And please kindly send your case presentation. If you haven't, either send it